I'm very happy to be here today. Well, when I was invited to present to this group, I was like, I do a lot of different things. I don't do anything exactly directly with diabetes, but I realized that one of my areas of research I've done quite a bit of work on actually has implications for diabetics. And it will be an area that I'm hoping to get back into and build up data capacity and research capacity around. So I'm very pleased to test out some of these ideas, present some of the work to you, and hear your thoughts and questions. So I'm going to share my screen. I have to make sure I got the right one. And then start my slideshow, in which case I will only see, I can see people in my slides. All right, so I'm going to talk to you about diabetes. I'm going to talk to you about obesity. Not in the way you've probably heard it discussed. Typically, a lot of work in obesity deals with weight management, obesity prevention, or the health outcomes. I'm interested in obesity because of my interest in pharmacoepidemiology. So this is the study of how medications get used once they're past phase 3 and 4 clinical trials. So out in the community and typically on people that were not in the original trials. So that's what I'm going to be talking to you today. And what I'd like to hear in the discussion is where you think this could be developed for diabetics or research with diabetic patients. So I have no disclosures. I have no financial conflicts of interest. To date, all of my funding has been from Canadian sources that are federally, basically tax dollars. And now I'll be moving into the US system. So I'm going to talk to you about obesity, people with obesity and prescribing, and then I'm going to give you the results from 2 studies that were part of one of my trainees' work, and then we can get into a discussion. So one will be about antibiotics and asthma, and you're going to see why this is how it relates to diabetics, and the other is one's for antibiotics, one's for asthma treatment, and they're both in patients with obesity, and then we'll look at implications. So the interesting thing is this, originally a lot of this information, I'm missing some of my text down there. A lot of this information was from Canada, but Canada and the US parallel each other fairly closely with this. So 60% of adults are considered overweight, and over a quarter of those are considered obese. And this proportion is expected to double in the next 10 years. I think actually this proportion is already higher. I don't think COVID has done us any favors in terms of weight management. The important thing is that 1 in 10 premature deaths are attributed to excess weight, and it's a second leading cause of preventable death. So obesity is right up there with smoking. Now, we could have a whole discussion about whether this is preventable or not, but the reality is it's a major health implication. So I also want to talk a little bit about one of the reasons I'm interested in obesity, in addition to its role in prescribing, is also its role in precision health. And as you know, we have the next gen here, and there's going to hopefully be some research capacity building around this. So people with obesity are more likely to have poor clinical outcomes, and this is the important part. They have blunted responses to medication needed to treat infections, which I'm going to talk to you about, rheumatoid arthritis, thrombotic disorders, asthma, again, I'm going to present to you, pain and depression. Depression is one that's currently being worked on. I won't present those results, although we have some initial results from that work. GWAS evidence, and I'm hoping the Next Gen Institute starts building up their GWAS research capacity, suggests there's a shared genetic pathway for the development of obesity with other chronic illnesses, and where this will be of interest for this group. And so in addition, like people with obesity are getting hit with a double whammy. They have the fact that they're less likely to respond to medication, but also the likelihood that they are more likely to have obesity because there's a shared dysregulation pathway in terms of the genetics. So this is true for cardiovascular disease, hypertension, depression, diabetes, asthma, and cancer. So you get this, when you think about modeling, it gets very interesting, but it also means that we should be considering this separately as a very important modifier or predictor. So why we care. So excess fat may affect disposition and effectiveness of most commonly prescribed medications in primary care. So what people don't realize is that while there's a lot of hospital-based prescribing going on, most medications dispensed in communities are prescribed by family doctors, and typically half the population's on a medication. So medications are used a lot. And for any of you who are into the pharmacokinetics or pharmacodynamics, so fatty infiltration of the liver influences expression activity of any cytochrome P450 enzymes, which may have significant prescribing implications. Two other things, and these are important. Usually people who are recruited for randomized clinical trials to test safety and effectiveness are not obese. They may have excess weight, but they would not be necessarily obese. This is often an exclusion criteria. And this is the important one. There are no guidelines for excess weight. And you're going to say, wait, there are some things that are prescribed by weight. Yes, there are. For example, intravenous antibiotics in the hospital, but not excess weight. So let me give you an example in kids. If you have a kid that weighs 95 pounds, okay? If that child, there's a big difference between a child being 4 foot 5 inches and a 95 pound 5 foot 10. And we've both seen those kids, right? When we were growing up, I was a skinny string bean that was always tall, and my brother was the opposite of a skinny string bean, although he eventually sprouted up. So at a certain point, we may have had the same weight, but we would have had a good half-foot difference in height. So that weight is not metabolically the same. So while we might adjust for weight for only very specific things, we do not have anything that helps us adjust for excess weight. And this is problematic. So a lot of my research has been on this so first we looked at antibiotics and obesity, because obesity is an independent risk factor for many infections. We all know the issue with antibiotics and antibiotic treatment failure and antibiotic resistance. The other thing is that obesity is strongly associated with worse outcomes. So people are more likely to be hospitalized, to have ongoing infections. And on the pharmacokinetic side, excess weight has been shown to alter antibiotic disposition profile. So this is talking about how you reach therapeutic targets. For anybody who's actively involved in prescribing, clinicians tend to prefer to be careful and conservative and safe, so they tend to start at a lower dose. And for some medications, especially the areas I've mentioned, that means especially in obese patients, less likely to achieve target. So we wanted to do this research to see, is this really the case, or because people with obesity tend to have a lot of other things going on, is it something else that is impacting this? So we define, oops, I gotta stop fooling around with my mouse. So antibiotic treatment failure. So this is when there's a failure to achieve therapeutic targets due to inadequate antibiotic dosage, and it might be one reason for treatment failure. So there's a lot of different reasons for treatment failure, including resistance to antibiotics and different things like that. When there's treatment failure, this is when you need a second course of antibiotics, or you may end up hospitalized, or you may die. So we wanted to know whether excess weight was associated with antibiotic treatment failure. And this was the first large population-based study to investigate this problem. And I'll talk a bit about the data sources. So here is basically a visual of what happens. So you have a normal weight patient with bacterial pneumonia, and there's a flat dose recommended. They have uniform drug distribution, and you get a clinical cure. The patient with the excess weight, same dose, only a partial uptake of drug into adipose tissue, and less unbound drug available for pharmacological activity. So there's a reduced ability to achieve therapeutic targets. So this was our hypothesis, and we wanted to know, would this be strong enough to result in treatment failure. And I'm going to admit somebody who's not anymore. Okay. Oh, I don't seem to be. Okay. So our objectives were trying to predict antibiotic treatment failure, and we define that as a secondary antibiotic prescription or hospitalization for infections within 30 days following an initial therapy when compared to normal weight people. And we wanted to know whether the lack of weight-based antibiotic dosing was associated with this. We were looking for a dose response, or the lack of a dose response. So we have some access to some interesting data, and I think that one of the things that will happen at Missouri over the next little while will be building up some similar data sources. So Quebec is a province of 7 million people. Most we're kind of like most of us live down along the border, close to the US. So that's Vermont immediately below us. Vermont, New Hampshire, New York, actually. And so Quebec is the payer. The provincial government pays for healthcare, and they pay for medications for a certain proportion of the population. They also do surveys. Now, this data is a bit dated, but they do surveys and where they do a random survey of the population, and we all have something called the French translation is a sunshine card, and it's the Régie d'assurance maladie de Québec is our insurance. So they're the provincial equivalent to United Healthcare. And so basically they ask people to consent to link the surveys to all their administrative health data, and we have a lot. Now, what we don't have is clinical data. So, sorry, I think I just swallowed a fly. Okay, so we don't have clinical data, which is, okay, that was horrible, which is labs. So I wouldn't have the result from any bacterial smears or things like that. So we'll come back to that in a second. But we had 18,000 people where we had all their administrative data. And the survey data is where we get the BMI, so the height and weight of the patient, because in the administrative data, that doesn't exist. And actually, it doesn't always consistently exist in clinical data either. So we took adults 20 to 79 years old, dispensed at least one orally administered antibiotic during the course of follow-up. And these are, in case you're wondering, these are the antibiotics that we looked at. And they're ones that we would expect that extra adipose tissues to be implicated. We excluded people if we were missing their height or weight, if they were underweight. And then we looked at things that would significantly impact weight. So they might be misclassified as being obese when they weren't, and that was pregnancy, bariatric surgery, if they had a chronic infection such as tuberculosis, recent history of antibiotic use, so within the last 30 days, no Quebec public drug insurance coverage during the outcome assessment period. That would be a small portion of the population, and death of non-infectious cause or loss to follow-up. So if they move out of the province, and yes, we track everything like that on people in the province. So we used StatsCan body mass index. The interesting thing is that there is actually a correction, a validated correction for self-reported BMI. So men overreport their height and women consistently underreport their weight. So there's actually a statistical correction for that, which we applied. Okay, other things, in case you're wondering, we controlled for everything. So we had socioeconomic status, which we know within a block or two, the average income in that area, as well as education level, all those things. Time of year, this was a proxy for potentially inappropriate prescribing, smoking, drinking, Charleston Comorbidity Index, antibiotic resistance. So how we define that is when people had a diagnosis for skin and soft tissue infections commonly linked with antibiotic resistance. So methicillin resistant Staphylococcus aureus, so MRSA. That was our proxy for antibiotic resistance. Temporary antibacterial resistance defined as previous history of antibiotic use was, so with this, we looked at whether within the preceding year of our start date, whether they had been hospitalized for an infection or prescribed any antibiotics in the previous year. So there was a variable for that. So our patient groups were people hospitalized for an acute infection or people receiving an oral antibiotic. And our definition was basically if they were rehospitalized or were given an additional antibiotic, depending on which group they were in. I'm not going to spend a lot of time on that. We looked at antibiotic daily dose because when you get our prescribing information, we have the type of prescription, the number of pills, the dosage, and the duration. And we did a daily dose and BMI ratios based on all of that information. Statistics, we did the logistic regression. I'm going to skip through that so we have time for discussion. So anyways, we ended up with 6,000 people in this study. Almost 13% had an antibiotic treatment failure event during the follow-up period. That's actually pretty high. It was higher than we expected. Most of these were additional prescriptions or modifications to their existing prescription. 3% were hospital admissions or readmissions or death with an infectious cause. So that was actually, when you think about the time period we were looking at and the numbers we were looking at, that was kind of high. So I'm not going to spend too much time. This is just a table that is impossible for you to read. That is really the description of our study. I want to just point out that patients without antibiotic treatment failure, 6.8% were diabetic, and with antibiotic failure, that number went up to 8.6. So a total of 7% of the people in the study had diabetes, or sorry, it was actually 8% because it was diabetes or diabetes with complications. So that was if they had retinopathy or different things. This is important because for those of you working in diabetics, you know things like foot ulcers and all the things that are the infections that are the number, or sores that are the number one cause of amputation. So this is, there were other things going on with these groups, but that was a big chunk of them. Essentially, of course, being antibiotic treatment resistant was the biggest predictor of suffering antibiotic treatment failure. But even after controlling for that, being obese increased your risk of having antibiotic treatment failure after controlling for all of these other things. So after controlling for all of your and this, there's not everything here, but Charleston Cornwall being in and everything, just by virtue of being defined as being obese, you had a higher likelihood of having antibiotic treatment failure. And that's accounting for history and resistance and alcohol consumption and all the rest of it. One thing, so when we were investigating this, what the take-home message from this graph is, the line is flat. So the adjusted daily dose did not move by BMI category. If you were thinking about it, this should have gone up, right? They should have gotten a higher dose if they were bigger. When you think about it. So I presented this to clinicians before, and they're like, well, there's no guidelines. And I'm like, are you really telling me you're going to take a 82-year-old elderly lady that looks like a bird and weighs however many pounds, is like 100 pounds if you're lucky, and you're going to give her the same dose of antibiotics as a 350-pound male construction worker and expect it to work the same? And so, but they're like, but there's no guidelines. Actually, and then they said to me, oh, the reason you found that was that people with obesity don't take their medications. I was like, did I miss something? So we actually went back into the literature, and there's not one single empirical study saying that people with obesity are less likely to be compliant with treatment. Now, polypharmacy, being on a lot of different medications, impacts adherence, and it might be the case for some of these patients, but there's no evidence of that. So essentially, you've got a physiological thing happening that people are writing off to a behavioral issue. And this is what I call obesity bias, and what I think is a big issue, pun, I think is an issue in some of what we're doing in population health. So significant predictors were obesity, and dose was not being increased for patients with excess weight. So this is one of the topics I would like to follow up further in different areas of prescribing and provide evidence and support to adjust dose. And there's an article available. I'm happy to forward any of these. And this has led to weight-based dosing pharmacokinetic studies in obese patients to optimize antibiotic delivery. So another example was obesity and asthma. Now this one was interesting because both obesity and asthma are significant public health concerns. It's the most common chronic disease among children in the developed world. And much like diabetes, there isn't an exact correlation, but asthma has paralyzed, a rise in asthma incidence has paralyzed the rise of obesity, the diagnosis of obesity with people, and it affects approximately 300 million globally. Now, excess weight is associated with an increased incidence of asthma, but it's not as straightforward as you might think. So there's a lot of conflicting evidence about kids having obese children with asthma who are obese having more exacerbations. So one of the things is this may be due to a lack of clinical severity indicators, and one of the things with asthma is a diagnosis. There's very specific criteria to make sure you have a diagnosis. So it's unclear whether children with asthma who have excess weight had a form of asthma that was difficult to control, and or whether they tend to have reduced exacerbation-free time. So we're like, there is a lot going on here. By the way, there is a specific asthma phenotype for adult women with obesity. So there is something going on here. So we wanted to know, we were going to look at predictor to first time of exacerbation on children with mild to moderately severe asthma using a clinical database. And that's because the treatment recommendations. Once you get into severe asthma, it's completely different. So we took a retrospective cohort from a clinical database that was linked to all this great administrative databases we have that capture all the hospital visits and everything else. So we took children 5 to 17 years old with a clinically confirmed diagnosis of asthma. So they were followed at an asthma center. And we did this through 7 years. And so they had to be we took them, included them when they received a newly stepped up treatment regimen. So, and we excluded them if they had cystic fibrosis, bronchopulmonary dysplasia, or if they were not covered by the public drug insurance plan for at least 3 months prior to the entry, because then we wouldn't know what drugs they have. That was a relatively small group. We tend to have very generous coverage for minors in Quebec. So we took the date of first exacerbation and followed them. We were looking at age and sex-specific BMI, because as you know, what is considered obese changes it depends on the age and the sex of the child. And that was done from weight and height measurements at the index visit and subsequent follow-up visit. So that could be time varying. We allowed that to be time varying. And we were looking at any emergency department visit, hospital admission, or use of oral corticosteroids for asthma during the follow-up. So when they were dispensed an oral corticosteroids, which would show up in our database, we knew that was for an exacerbation. And we used a time-dependent Cox model for this. By the way, we did have a lot of information on their home environment in addition to all their health service utilization. So the final sample was 355 pediatric patients naive to the initial treatment. During that time, there were 234 exacerbations. There could have been somebody who had multiple. And what we found was that for every 10-unit increase in the BMI percentile, the hazard of an asthma exacerbation increased by 31%. And there were no significant differences in prescribed maintenance therapy regimen on, so regardless of what you got, you had this increase based on weight. So essentially, children with a higher body mass index percentile, so if they're in the 90th, 95th, were more likely to fail and have an asthma exacerbation earlier than those with the lower BMI, and we were looking at why. So when children with obesity present, they're generally what's called non-atopic severe, so they have a lot of symptoms and difficult to control. So one of the things is that there's different forms of inflammation of the airways. So think of it this way, you can get an inflammation of the airway, but you can also have a mechanical thing with the excess weight on your chest, making it more difficult to breathe. And most treatment guidelines are based on eosinophilic clinical phenotypes. So sorry, but in obese children, they have another phenotype. So the idea is that they may respond more favorably to a completely different treatment initiation. There's also evidence of reduced response to inhaled corticosteroids, and that's the cornerstone of asthma maintenance therapy for pediatric patients. One of the challenges here, so we wouldn't be able to tell if people weren't taking their medication, or if it wasn't getting far enough in the lungs, it doesn't show up in the hair, right? So you can't say whether or not it's being done. And also, if part of it is a mechanical issue where there's weight pressing against the chest, that is a problem. And this has been published, and there's 3 or 4 studies out of this now. And so when you think about this in terms of patients, there are so many potential explanations for why they might have a poorer treatment outcome, including very strong physiological ones. So what we want to do next is try and distinguish, and this is hard because even in kids, the incidence of non-alcoholic fatty liver disease is going up. So people look skinny and they got a lot of fat in their liver. So we want to try and investigate the difference between weight-based and excess weight. So can we make that distinction and look at other drugs affected by weight in terms of current prescribing practices and health outcomes? So there's obesogenic medications. So right now we are doing a lot of work on antidepressants, but there's contraceptives, antihistamines, and antidiabetics. And there's lipophilic medications affecting therapeutic effectiveness. And so antihypertensives, statins, and antidiabetics again. So you can see why this might be an area that would be of great interest for any research in diabetes. So I think